Assalamu alaikum warahmatullahi wabarakatuh. Today we're going to be discussing the anatomy of the pleura by Dr. Olena. So I have taken her slides and made it more simpler for us to study and revise from it in the same time because we have such a short time to study the CVP. This is my number. If anybody has any questions regarding this lecture or any other lectures, I'll be more than happy to help. Okay, so let's start. Our objectives are very simple. We're going to be discussing the surface anatomy of the lung and the pleura and the pleural cavity, and also some clinical cases regarding the open pneumothorax and thoracentesis. Okay, let's start. Let's start from a basic knowledge. We all know the lung. We all know that the top of the lung sticks slightly above the clavicle and the bottom of the lung slopes downward as we move from front to the side to the back. When I mean from front, I mean by the sixth rib, okay? And when I mean by the side, the eighth rib, and the back posteriorly is by the 10th rib, okay? This is just the general information. You don't need to memorize anything here till now. Okay, fissures. Fissures are really important. We have two types. We have the oblique fissure and we have the horizontal fissure, okay? The oblique fissure presents in both lung, okay? The oblique fissure, as we can see, here's the oblique fissure and here is the oblique fissure, okay? In both lungs. It runs from the back to the front. It runs from back of the lung till the front of the lung, okay? Where it starts, I've mentioned where it starts, but it's not that much necessarily to know, and where it ends too. We should know that this is the most important part of the fissure, which divides the upper and lower lobes, okay? Divides upper and lower lobes, and the middle lobe on the right side, because the left side doesn't have a middle lobe. Okay, the horizontal fissure presents only in the right lung, okay? The horizontal, as we can see here, it only presents in the right lung, and I've also attached the right lung, okay? So we can see it from different perspectives. It runs horizontally and extends. I've mentioned that we don't need to know where it runs, where it extends, okay, and where it crosses. We just need to know that the horizontal is only on the right, okay? Horizontal only on the right. Oblique can be found on the left and on the right, and the oblique one divides the upper and the lower and the middle lobe, okay? We can see the upper and lower and the middle lobe. Okay, so I put here an easy memory to remember. The oblique, it's both lungs, okay? The oblique, we find it in both lungs. Horizontal, only in right lung. And if you want extra information, you can say that the oblique is from the T12 to the sixth rib, and the horizontal one is only the right lung and only in the fourth cartilage. Okay, auscultations. Auscultations are very important. I think that they will bring something about it. Auscultations, we can see superior auscultations in the superior lobe, middle lobe, and the inferior lobe. Let's start with the superior. When I say superior, I mean anything that is beginning in the first, okay? Upper. So we have in the right lung, okay, above the fourth rib, which is the anterior chest wall. But in the left lung, it's above the sixth rib, okay, also anterior to the chest wall. The medial one, the middle lobe, okay, best heard anteriorly. Okay, so we put the stethoscopes anteriorly between the fourth and the sixth rib. And the inferior lobe, which is the آخر واحد تحت, best heard on the posterior chest wall. Okay, you hear it from here. So we've learned that the superior and the medial, we can hear it from the front or anteriorly. But the inferior one, we can hear it posteriorly. The pleura. We have two types of pleura. We have the parietal pleura, and I've attached the images here. So let's just read this out and see the images. The parietal pleura and the visceral pleura and its pleural cavity, which lies between the parietal and the visceral. When we say the parietal pleura, okay, it lines in the thoracic wall and divides into four regions: the cervical pleura, the costal pleura, the diaphragmatic pleura, and the mediastinal pleura. When I say the cervical pleura, it extends into the neck, the cervix, the cervical, isn't it? And the costal, when I hear the word costal, I directly link it to the rib cage. Diaphragmatic, diaphragm. Mediastinal pleura, mediastinum. Okay, so by its name you can link it. The parietal one is the outside one. Okay, the outer one, while the visceral one is the inside one, because the visceral firmly adherent to the lung surface. Okay, it covers the entire outer surface of the lung, extends into the fissures themselves that we just discussed between the lobes, cannot be separated from the lung tissue. The pleural cavity is the space between the parietal and the visceral pleura. It's the potential space between the parietal and the visceral pleura. Contains thin film of a serous fluid, okay? Allows layers to slide with a minimal friction during breathing. So it helps us in breathing, okay? It's lubricating the lungs so we can breathe and expand and constrict. This is their photos. This is the parietal pleura, the outer one, okay? When we say parietal pleura, we can see it here, the outer one. And here is the visceral pleura, the inner one, that directly adherent and sticks to the lungs. And here is the pleural space, which is the space between the parietal and the visceral, okay? Filled with serous fluid to help us breathe. Not to help us directly breathe, but to help us when the lung expands, so it gives us some space and it's adherent to the lungs. Okay, costodiaphragmatic rhesus. It's actually so important. I cannot say how much important is that. It's the space that is shown here. I've attached an X-ray, okay? We can see it. It's beneath the lung, okay? Why did they call it costodiaphragmatic rhesus? Because it's under the costal and upper to the diaphragm. So it's between them, just like the pleural cavity, isn't it? Let's read. It's the space between the bottom of the lung and the bottom of the pleura, okay? The lung stops at a higher rate. The pleura goes lower. That extra space is called costodiaphragmatic rhesus. So, do we understand? If yes, that's good. If not, when the lungs goes up, okay, and the diaphragm goes down, there is a space here that is created. It's called the costodiaphragmatic rhesus. Why is it important? Because during deep breathing, when we deep breathe, the lungs can expand into the space, okay? It's just like an extra space. Fluid collects here, okay? It's the best place to drain the fluid, like the pleural effusion, okay? Its location at the corner between the ribs. When I say corner between the ribs, what I mean by costo. And diaphragm is diaphragmatic. So its name is costodiaphragmatic rhesus. So if the exam, I saw something about costodiaphragmatic rhesus, I know directly it's beneath the lung and upper to the diaphragm, okay? Helps us in what? In deep breathing, okay? Open pneumothorax. What is open pneumothorax? I've attached some few images, okay? An X-ray and a cartoon and an anatomical. It should be anatomical, but I don't know. That's how I tried making it, okay? What is it? It's basically air entering the pleural cavity from outside the lung, which makes the lung collapse, okay? In the X-ray, we all know that we can see the black stuff as air, isn't it? So when I see here most of the right lung is black, that means that the lung has collapsed and has shrunk into this smaller space, okay? So that means that we have an open pneumothorax. How does it happen? Usually from a stab. If there is a stab to the chest, okay, a gunshot or a chest injury, we are piercing the pleural cavity and we're piercing the lung, so the lung cannot expand and contract and make us breathe. What happens to the air? Air moves and out through the chest wound that have been stabbed, okay? Inspiration air enters the mediastinum, shifts to the opposite side, expiration, air leaves to the mediastinum, shifts back. So basically the air goes front and then goes to the back, and it just goes to any place except the lung, because the lung has been punctured. Okay, why is it dangerous? This affected lungs could collapse. The mediastinum shifting compresses the other lung, because if I collapse this lung, all of the oxygen and all of the pressure is gonna go to the other lung, isn't it? Making breathing harder for the patient. The nerve supply. The nerve supply is also important. When we say about the nerve supply, we have the parietal pleura and we have the visceral pleura, okay? So in the parietal pleura, we can see that the somatic sensory is a very sensitive, okay? It's what's providing the nerve supply for the parietal pleura. We can feel pain, temperature, touch, and pressure, okay? When we say costal pleura, intercostal nerves. It's by its name. Mediastinal pleura, phrenic nerve, okay? Diaphragmatic pleura, phrenic nerve, the central part of the phrenic nerve. Okay, and this one is not important. Why is it clinically important? Because the parietal pleura pain is very sharp and well localized, so we can feel it by the somatic sensory. Okay, it's a very recall slides. You can just stay on it and keep repeating it. Okay, we have the visceral pleura. Okay, it's controlled by the autonomic nerve supply, which supplies the pulmonary plexus. Insensitive to pain and temperature. Just think about it. Parietal is outside, visceral is inside. So can you feel whatever inside there? No. But parietally, the outer one, we can feel it. We can feel the pain, the temperature, the touch, and the pressure. But inner side, which is the visceral one, it's insensitive to pain. We cannot feel the pain and the temperature and the touch. Only sensitive to stretch when it stretches. Okay? The clinical reason is when we have that visceral pleura problems, okay, we can poorly feel the pain. Okay, we don't feel the pain directly as much as the parietal pleura. We can poorly feel it. So I've attached a quick memory here for you to understand the parietal and the visceral supplied by which nerve and the sensation. Here we have a big sharp pain, لأنه وجع. And here there is no sharp pain because it's visceral, it's inside. Okay, the borders of the pleural cavity. We have two borders, the cervical pleura and the costodiaphragmatic rhesus that we just explained. Okay, we know what's costodiaphragmatic rhesus. It's the place where it collects fluid there. Okay, so we can expand the lung when we hard breathe. Okay, but it has one of the clinical problems. It has fluid collects which can cause pleural effusion. That يعني هذا الكلينيكال حق. Okay, the cervical pleura is located at the top of the pleural cavity, can be injured during a subclavian vein insertion. Okay, it's important in clinical risk. Why? Because the subclavian vein could be injured. That's it. I want you to link that the clavicle pleura, the cervical pleura, can be injured by the subclavian vein. Okay, it's conquering the cervical pleura. While the costodiaphragmatic rhesus, the space that we just talked about, can be, the fluid inside it can have problems. Okay? Okay, so we have three types of diseases. Okay, we have their pictures here. The first type is the pleuritis. Okay, it's an inflammation to the pleura, causes pleural adhesion. Okay, inflammation to my pleura causes pleural adhesion, التصاق في البلورا. Rough pleural surface, rub, okay, that makes something called friction rub. يعني تسمع خشخشة, okay, when you breathe. Heard with a stethoscope. If you put a stethoscope on the chest, you can literally hear something rubbing, okay? Fluid level can be seen by an X-ray, just like here. Pleuritic pain is a sharp chest pain, worse with the breathing. As much as you breathe, as much as it gets worse. It's affecting the costal pleura, pain felt in the chest wall, through the intercostal nerves, okay? While the mediastinal pleura, pain referred to the shoulders. When we have a mediastinal pleura pain, the shoulder is what's most painful thing there. Why? Via the phrenic nerve, because the phrenic nerve passes there. And we have the thoracentesis. It's a technique that's used to remove the air or fluid from the pleural cavity. Where it's actually important, you have to know where. It's between the 7th and the 9th intercostal space. Exactly where? In the mid-axillary line. Okay? In the mid-axillary line. The technique is we insert a needle in the upper border of the rib to avoid the intercostal bundle, as here. See, this is the pleuritis, the air that can be seen in the chest x-ray. And this is the pain that can be felt and be injuring the phrenic nerve or the intercostal nerve, according to where the case is. If we have a problem in the costal pleura, we can say intercostal, mediastinal, phrenic nerve. Okay, and thoracentesis is here where we inject this needle to withdraw the air. Okay, or the fluid, the excess fluid that is there. Okay, this is the end. That's it. We just finished the lecture, but we just have few questions. Oh my God, I forgot to remove that, and it's actually so embarrassing. I forgot to remove that. It's just a silly thing that I was joking about. Okay, question 1. During the thoracentesis to removal, okay, a patient felt a twinge of pain as the needle enters the pleural sac. Which nerve's fiber carried the painful sensation? So let's get back. Here, what did we say? We say that if we have a problem, pain felt, okay, and the thoracentesis, it's between the 7th and the 9th rib in the intercostal space. So if we heard the intercostal space, we can definitely link it to the intercostal nerve, isn't it? Intercostal nerve. So our answer is the intercostal nerve. Okay. Question number 2. Thoracentesis is performed to aspirate an abnormal accumulation of fluid in a patient with a pleural effusion. صح. A needle should be inserted at the mid-axillary line between which of the following two ribs to avoid puncturing? We just mentioned it. Okay, it's between the 8th and the 10th rib. You see it here? It says usually they may bring, if they bring 7th to 9th, that's correct. But if they did not bring it among the answers, we can just pick the nearest one, which is 8th to 10th. Okay, 8th to 10th. Where is it? 8th to 10th. Okay? Okay. What's the name of the thin, transparent serous membrane that lines in the inner surface of the thoracic cavity and covers the lung? And هذا سؤال so easy. It's called the pleura. Which surface landmark corresponds to the lower border of the lungs during the quiet respiration in the mid-clavicular line? This one I just memorized it, and it's the 6th rib. Okay, so I just linked it. Whenever we hear the mid-clavicular line, we just link it to the 6th rib. Okay. The pleural cavity is located between which two anatomical structures? This is very easy. The pleural cavity is between the visceral pleural and the parietal pleural. Okay, so whenever we hear something between the cavity, we just explained it, it's between the visceral pleura and the parietal pleura. Okay, question 6. Which of the following describes the function of the pleura? Its function is so easy. It's to provide lubrication and reduce friction during breathing. Okay, so it's C. Okay, during thoracentesis, where is the needle typically inserted to access the pleural cavity? We said it's between the ribs and the intercostal space. Okay, so it's B. Okay, a 55-year-old patient with a history of chronic smoking, okay, and exposure to epizootosis. خلينا نقول إن we don't know what the epizootosis means. Okay, present with a chest pain and shortness of breath. Imaging studies reveal a pleural effusion in the pleural effusion fluid that accumulates where we just said pleural effusion. We have problem in the pleura. So it's where it's in the pleural cavity. That's so easy. Tamam? Just make the questions easy. Don't make them overcomplicated. They're already so easy. They just try and trick us. By the way, these questions are from Dr. Olena. So they're very, 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 very important. Okay? So what is the primary purpose of the thoracentesis procedures? We said it's to drain the fluid from the pleural cavity. Okay? Is it to remove the fluid from the mediastinum? No. To do a biopsy? No. To examine the bronchial tree? ما لها دخل. To treat the pulmonary embolism? No. It's basically to drain the fluid from the pleural cavity. And 10, which is the last question, what is the most appropriate anatomical landmark for performing a thoracentesis? It's in the mid-axillary line at the 8th intercostal space. زي ما قلت لكم 8th ليش؟ لأن إذا ما شفنا 7 تمام بتكون ممتازة. فنقدر نقول it's between the 7th to the 8th أو من 8th to the 10th. Okay, فعندنا in the mid-axillary line at the 8th intercostal space. طبعا هذه كانت محاضرة صغيرة واللي عنده أي استفسار يتواصل معي وبإذن الله I'll be more than happy to help you. Good luck with your studies, guys. Bye.